Okay, so thank you for having me here to speak. I must say I was here in November for the first research symposium, and I'm really excited to be here again because just what UIUC has done over the past 3 years is phenomenal, and I've really enjoyed sending many different universities, schools, communities even in the direction of SHIELD as an example of what can be done for the safe reopening of communities. So I'm going to be presenting on something very similar, but also something a little bit different in our approach of what we did with our saliva testing, our saliva test. So our work, much like everyone else's, started very early on in the pandemic, and basically what we saw in March 2020 was just all the challenges that were being experienced with this gold standard nasopharyngeal swab. So of course the gold standard had to default what was being used for other respiratory pathogens, and we just had to hope that it would also work for this novel respiratory virus. But they are an invasive sample type. This does mean that a trained healthcare professional is required to take that sample. And I think prior to the pandemic, not many people actually realized how uncomfortable they are. I'm assuming that most of us in this room now know how uncomfortable they are and how that this can actually lead to testing aversion. And they can also be a risk because of that irritation. People can potentially sneeze on healthcare workers, and thereby, potentially spreading the virus further. And so we were trying to get a biobank off the ground. We were trying to sort of build up a biobank of different samples so that we could study COVID-19 disease progression and also SARS-CoV-2. And, we had healthcare workers who were hesitant for this reason to take additional swabs for research. We had, scared outpatients who really didn't want to sign up for additional swabs when they had already experienced one and weren't really sure what was going on with them. So we wondered if there could be another approach to this, and my background is actually in saliva. I've been using it as a sample type for the detection of a bacteria, Streptococcus pneumoniae, for about the last, I don't know if it's like 12 years now. And not having worked with viruses, not having worked with RNA, I just very naively wondered whether saliva could also overcome many of these challenges that we were seeing here. Fortunately, our team was supportive enough, maybe also a little bit desperate enough, just to compare the results of what we'd see in saliva versus nasopharyngeal swabs. And by the end of March 2020, we had built up this data set from COVID-19 in patients where overall we just found that on average, saliva was finding more SARS-CoV-2 RNA in samples as compared to that gold standard nasopharyngeal swab. So this leading us to try to develop this further as a sample type to aid many of these testing challenges that we were seeing. We also had a little bit of optimism for the frequent repeat ongoing testing that we would require, and this came from a very small data point from our healthcare workers. So this is sort of nestled in our first original paper, but there were 9 individuals who first tested positive in saliva, and I think this should also come as no surprise again from some of the great work that's come out from UIUC since, and also Caltech and the University of Maryland. But being March 2020 and seeing that our saliva tests were testing positive first before nasopharyngeal swabs it actually caused a bit of concern. It sent a lot of these people for repeat tests many times because we wondered whether there was something actually wrong with our saliva test. But again, it was a small data set, but again, it gave us hope that this could be something to be expanded on further. We were also seeing just that saliva was providing a more reliable sample type. So these are the values for the human RNase P gene target. So if you do a PCR test, you'll test for the virus components, but we also test for a human marker because you can use that to make sure that your test is actually running properly. You do have human material in there. And basically what you see is this spread that you see with nasopharyngeal swabs is really quite great. And you might think of an explanation for this for those who really don't like their nasopharyngeal swabs. It really, really hurts. And then you have others who say, barely felt anything, that didn't hurt at all. Well, that's probably this person down here that barely picked up any human material because the swab wasn't taken properly. And if you think about it, if you're not taking a swab properly, you're likely then to also not pick up enough virus material, and this could also lead potentially to false negative results. Whereas with saliva samples, what you see is basically what you get. You've got sample in there, and we're seeing much more consistent samples overall. So again, this was just something that led into our early observations about why saliva could help to be a solution here. So this is just a summary of everything that we then went on to do. So so that was sort of what set the stage at the start of 2020. We then we've just for the year following that, worked to continue to validate and optimize saliva as a sample type. We thought about it as a way to provide a low-cost testing solution. So again, first of all, having established that saliva was comparable to that gold standard, we then worked to demonstrate that good quality saliva samples can be self-collected. So for this, we actually sent out saliva collection packs to study participants, didn't really tell them what was going on. We met them on Zoom, we turned off our cameras, we turned off our microphones, and we just watched them collect saliva samples. We asked them a bunch of questions, and basically all the participants felt that they could reliably collect their own saliva samples, that they did so properly, that they did so confidently. And when we received those samples in the lab, the majority were of sufficient volume, they were easy to pipette, they were true saliva samples free from food particles. So this was really because, again, saliva is not a traditional diagnostic sample type, and many of the hesitations that you get from labs who are thinking about transitioning into using saliva as a sample type is this sort of very commonly said question about, can good quality saliva samples be collected? Can they be, can you work with them in the lab? So we, and like many others have now shown, is that when you have really great, clear collection instructions, you can get good workable saliva samples. We also wanted to demonstrate or explore whether how stable detection of the virus was in these samples over time, because what we saw very early on, if you look at early March, we just sort of looked to see what saliva collection devices were out there, and they ranged anywhere from $28, $9, $7. And if you're thinking about setting up a sustainable testing program, if all your money is going into these saliva collection devices, that's just going to max out what you can do with your study. So the thing that all of those collection devices had were these proprietary buffers and reagents marketed for stabilizing RNA, and we wondered if it was needed. So we took saliva samples and we tested them on day of collection, and then we made aliquots that we stored frozen. We stored them at room temperature for 5 days and 30 degrees Celsius for 3 days. So each of these dots joined by the dotted line, that's the same sample in those different conditions. And we saw that detection remained relatively stable for prolonged periods at elevated temperatures. And this is our again, just a very, very haphazard study design of being sort of March, April, May 2020, and just having to sort of set aside spare saliva samples and find spare PCR runs that we could do. But, we had samples that we left in the biosafety cabinet for 25 days at room temperature that we had stable detection of SARS-CoV-2. So really indicating to us is that we did not need these really fancy collection devices. You can just use very simple laboratory tubes. We also demonstrated, we sort of dabbled early on to show that saliva can be pooled to aid mass testing strategies, and the likes of, say, Miramis Labs in Brooklyn, who have been also testing thousands of school children around the country, have demonstrated this much more extensively, but that was just an early idea, again, to sort of get to this point of can we make saliva a sustainable option for these low-cost testing programs. And we also just demonstrated that SARS-CoV-2 genomes can be sequenced from saliva, which kind of seems obvious now, but a lot of the push for swabs has been, hey, we need to have that swab because we need to be able to sequence a virus from it. And this is, so we just basically showed that you could do this just so that people can be reassured that if you have a saliva sample, you can also sequence virus from it, so you don't actually need that swab. And so again, all of this was in an effort to bring equity to SARS-CoV-2 testing, and then this led us to our RNA extraction-free protocol. So this is SalivaDirect, which we developed as a simplified and flexible platform to enhance those SARS-CoV-2 testing capacity. So again, much like the Shield test, it is very, very straightforward. It is that simple saliva collection. We mix ours with proteinase K, and then we heat and activate the proteinase K for 5 minutes at 95 degrees Celsius before testing in dual-plex RT-qPCR. So we're targeting the CDC's N1 primer probe region, and again, that human RNase P, which I mentioned earlier. So again, this has led to a non-invasive, less expensive, and circumvents supply chain disruptions. Now, how did we do that? We actually validated a range of different instruments and materials from different suppliers. So we wanted labs to be able to use what either they already had in their lab, so especially the qPCR instruments. We did not want them to go out and have to buy a new one, because that purchase price would just be passed on to their patients. So we thought it'd be faster, easier, also better for supply chain if they could use what they have. The same goes for the reagents. So we wanted to have a variety of reagents in there. We'd seen so many supply chains collapse throughout the first half of 2020. So we thought, well, if you've got sort of redundant materials in there, if one sort of runs out, gets short supply, they can pivot to something else. It also means that if we put in a bunch of different suppliers, chances are labs already have a good customer relationship with one of these suppliers, so that they can then just get sort of a better sort of customer bulk discount or something like that. So many of our labs, often this can get the price per sample down to $1 per test for the reagents themselves. We also, we needed to demonstrate that this approach would work for asymptomatic individuals. So we did this in partnership with the National Basketball Association, which was, again, up there with one of the most surreal emails I received during this time. But in the end, SalivaDirect ended up in both the players' home market, again, terminology that I didn't ever use prior to the pandemic either, and also in the NBA bubble down in Orlando. And if you haven't heard about what the NBA did, is that they had very, very extensive protocols in place. I received a massive document that was very sufficiently bedtime reading at some stage, but they had such protocols in place that they were doing such frequent testing that in the end we didn't get very many positives overall, because they were doing such a great job. But we did see good concordance when they were sending us saliva samples to be tested by SalivaDirect with their peer. It was an anterior nares and oropharyngeal swab in a single sample going off to Quest or bioreference. So we saw good concordance. It just wasn't quite the numbers that, of course, the FDA wanted to see. But we also worked to demonstrate that whether you're symptomatic or asymptomatic, like your viral loads can be similar. And again, this was something that came to us, especially from the FDA, very early on. And I mean, we were concerned about this at first, is if you're asymptomatic, what kind of viral load do you have? Are you a risk to other individuals? And if it's a low viral load, of course, we want to be able to demonstrate that we can capture those individuals. And so in the end, when we just pulled together some of the data that we had from actually some of our partner labs, we just saw, well, actually, there's not really much difference in viral load between symptomatic individuals and asymptomatic individuals. So this isn't really much of a point, but it was another data set that we sent into the FDA to support our case for asymptomatic labeling. So we did receive emergency use authorization for SalivaDirect in August 2020. It was described as the most unique EUA that the FDA has issued, and I think that remains pretty true today, because in the end we got designated as a manufacturer, but we don't make, sell, distribute anything other than the protocol itself. We just wanted to be able to make that protocol available for labs, and labs to be able to go off and get everything that they need to run that test in their own settings, and to have all of this sort of redundancy in the protocol so that labs can sort of pick and choose their own adventure, if you will. So we did have our first labs designated that first month. The emergency use authorization is open to all high complexity CLIA labs, and we have a very simple, straightforward designation process. So within sort of 2 business days, labs can get on board, which was actually quite it was actually really, really great to see this, because there were some times that, say, for example, like I think maybe it was like the TechPath reagent RNA extraction kit sort of had really run in short supply. So we had labs sort of scrambling to get their testing back up online, and they knew that they could really quickly, easily put this in, because they had everything needed on the PCR end, just they couldn't get the RNA extraction material. So that was a really nice example of how it provided a way for labs to very quickly pivot to keep their testing programs going when it was needed. We also continue to perform a lot of the regulatory affairs that are required by the FDA. So this does lower the regulatory burden of the labs themselves. And having done all that upfront validation work ourselves, again, that also leads into the quicker deployment time for the labs, and thereby also lowering their overhead costs. So I don't really quite know what I was expecting, but as this rolled out, just one of the most incredible things was to see this community that built up around it. So we have now designated 202 labs in 42 states and territories around the country. Over 8.5 million tests have been run through these different labs. And I think, we've got a sort of an estimate of several million more probably from the universities or colleges that actually ran this sort of off the EUA, because they weren't clear labs, but they ran it anyway. I actually, I think Southern Connecticut recently posted on Twitter or something that they've put this into their college program to have sort of people learning how to do PCR testing, and so it was quite cool to see that. But sort of trying to get this off the ground, we started running weekly calls, which went down to fortnightly and monthly, and now we've moved over to Slack. But we just had, we had a Google forum in place. We were hosting these calls just to sort of like really help anyone sort of on board, provide assistance. We were not a clinical diagnostic lab by any means, and so much of this was actually very new or unknown to us. So actually being able to bring these labs together and have them talking, and we actually had labs say to us, well, they've always worked in silos. They've never had a community of labs that they can reach out to and post some random question on a Google forum, or the sample exchange was really important, or a bunch of them put their heads together on how to do proficiency testing. Again, something I was not at all familiar with, but then they were trying to figure out how they could sort of find ways to sort of meet the regulatory needs that came with a sort of quite a novel approach to testing. And this community has been really, really essential for the ongoing expansion of SalivaDirect. It does provide us post-market real-world data that we do have to send back to the FDA. We like the idea that we could put in place, rapid public health response if you have situations of potentially novel outbreaks, or as quick scale up, scale down. But it's this pipeline expansion that has been really a result from the laboratory network, and this is again coming back to this flexible, adaptable protocol. So in the grey is where we started with SalivaDirect assay, so that was that table that I showed you earlier, and this is mostly where we are now. We actually have a few more reagents and a few more PCR instruments, but again, the labs would come to us and they would say, hey, this is reagent I can get cheaper, this reagent I can find easier, or I've got all these different PCR, whether it's a 16 well, 48, actually we've got a 48 well on here as well now, but the 384. So we basically had these bridging sets that we could just send out to the labs. We'd already run the data in our lab, they would run the data in their lab, they'd send the data back, we'd send it into the FDA with an amendment to our EUA, and I think we've made well over 25 amendments to the EUA in the last couple of years. And we also have, as I said, a full asymptomatic labeling. We put in quite early on to have a trained individual to observe collection, because originally the FDA wanted the healthcare provider to observe that, but we also have at-home collection, we have direct-to-consumer pooling. So again, this has been really through the community of labs that have really helped support us in that and just responding to what they needed. And with all of this going on, our LOD is anywhere between about 1.5 to 12 copies per microliter, depending on the different depending on the different combinations that labs use. We also have a number of different workflows now on the EUA. So this again was a result of the different labs reaching out to us, because this was our protocol, this is what the EUA said. But we had labs that were mandated by their local EHS requirements to heat pre-treat their samples before they could test them. So we had labs reaching out to us and say, hey, we need to have heat pre-treatment on here, otherwise we can't run your protocol. Can you bridge it on? Can you show us the difference? So we explored, in the literature, we sort of looked at what virus inactivation would be. So we tried the 95 degrees for 5 minutes, the 65 degrees for 15 minutes, and of course we had a number of labs who were interested or already using the 95 degrees for 30 minutes, which would be very familiar to this group as well from Shield's early work on that. And so basically we just did all the bridging required and showed that whether or not you use heat pre-treatment, whether or not you use proteinase K, you got very, very similar results. So again, allowing labs to sort of adapt this into their existing workflows. We also had added a pooling option, again in the spirit of SalivaDirect, just trying a couple of different options to allow labs to sort of implement this as best they do. Again, actually not many labs actually use pooling with SalivaDirect because it is such a simple, low-cost workflow, but it is there should they want it. So since summer 2020, we have known that the other respiratory pathogens would finally return, which they have in full force the last winter season. And so we had been wanting to expand SalivaDirect for the detection of other respiratory pathogens as well. So again, if you can have this quick, low-cost identification of someone who's got some respiratory symptoms, this can also help to lead to faster treatment. Now, if we do a multiplex PCR test, that is a limited number of targets as compared to the other extensive viral panels that are out there. But a lot of these viral panels, they're anywhere from $65, $90, $150 a test. And so if you can put just 5 viral targets, you can still keep a much cheaper test. Again, everything that we've set up with minimal supply chain pressures, easy implementable, and good for screening. And being an academic myself, I'm just also very excited about this prospect for research studies, because if we can have a very low cost detection of respiratory viruses, we can allow our research funding to go further, and then we can also get more data coming in that way as well. So when we were looking into expanding out for the detection of other respiratory pathogens, my greatest concern was, what about the stability? Because if the detection of in this case influenza A and RSV were not stable in raw saliva, this would just be a moot point. And so we were fortunate to get some samples. As a preface, we're not a clinical facing lab, we don't have access to the patients, so we've been very lucky to receive samples again from different labs. But basically the same thing that we had before. You have samples that were tested fresh, and they're at different conditions for anywhere from about, on this graph, I think it's like 3 days, 2 days, 3 days, 5 days, 7 days. We have very limited quantities of these samples, so we're trying to get creative in the different time series that we can do. But again, we're seeing pretty stable detection up to 7 days at these different conditions. Again, just supporting that this approach is applicable to other respiratory viruses. It also means that it's pretty flexible for outbreak response. So we were also very fortunate to receive a handful of saliva samples from lesion-positive Mpox patients. And when I say handful, it was literally 5 samples. And again, this was what we first wanted to validate was, again, is Mpox detection stable in raw saliva? And it's not as wonderfully stable as we see for the other viruses. One caveat to this is that these samples were diluted 1 in 10, because again we received a tiny amount of sample, and so we diluted it in a pool of negative saliva. And actually we also did a 1 in 100 dilution, and those were even less stable. So while this wasn't as stable as for the other respiratory viruses, we do see an effect of dilution with other people's saliva potentially impacting stability. So it still gave us some hope that if you have low resource settings, lack of cold chain, if you can even have samples sort of still out for 24, 48 hours, it can provide a possibility of being able to go through a raw saliva collection process. We also took those, well, actually just 3, so N equals 3. Again, small numbers, but again promising, because we took these samples again, Mpox positive from lesions, and we put them from lesion positive people, and we put them through the summer and winter shipping profiles from the FDA. Now what this is that for a period of 56 hours, these samples cycle from warmer to colder temperatures, or colder to even colder temperatures, to sort of replicate what might happen if you take a sample at home, you carry it down, you post it during the summer, it sits in the box, it moves into a van, it goes into distribution centers and back out again. So again, this was very stable, even though it's only the 3 samples, but again, I think promising preliminary data that is worthy of further expansion. So overall, and I think I might be preaching to the choir here a little bit, but of course saliva is ideal for mass testing programs. Again, saliva is the collection of all oral fluid, so just asking people to drool and discouraging sort of coughing or spitting or anything. Importantly, healthcare workers are not required, thereby reducing the risk of transmission and efficient for high throughput screening. and really supports this need for frequent repeat testing when you have these sort of outbreak scenarios going on. Having inexpensive self-collection is really valuable to making this simple and scalable. And what we are seeing is that it is really sensitive, at least for SARS-CoV-2, for early detection. Again, the work from Caltech, UIUC, and the University of Maryland. But it is really important that tests for saliva must be designed for saliva. So there have been many instances out there where, again, we've had to try with what we have. And so individuals would take a test that was developed for a nasopharyngeal swab, they'll apply it to saliva, it doesn't work, and they blame saliva, whereby, if they had tested blood in that method or urine in that method, they probably wouldn't blame the sample, but rather, hey, this is probably not the most suitable test for this very different sample type. So what we've been trying to do is really, really highlight this as often and as frequently as possible, is that there are incredible tests, as we've all seen, for saliva out there, and that people just need to keep that in mind, that if a test fails, it's not necessarily saliva, but the test itself. And how about looking into the tests that have been successful and maybe developing those further rather than starting afresh. So I think, out of everything that we've learned over the past 3 years, we have certainly learned a lot, but I think one of my greatest takeaways is this collaboration that we've seen between everyone, and I really, really hope that this is really something that we can expand upon further for future outbreaks, future pandemics, but just this idea that we just saw so many from government, industry, and academia all come together, instead of just sort of squirreling away on their own work, we all came together to try and help out in this common need, and this has really set a new standard for rapidly scaling resources, and this is really going to be key for addressing current and future pandemics. So with this continued collaboration, we can really address this worldwide need for accessible and equitable testing, the sustainable ongoing public health surveillance, and these robust networks that can be activated in times of need. And this is only a fraction of the people who have worked on all of this, but some who have been incredibly key to all of this. So thank you very much.
So how will your world change with the end of EUA?
Well, we're currently submitting for 510K. So we're working on that and how to get, again, something that's quite different than what the FDA has ever seen through the FDA. So I think even we're working quite closely with some regulatory consultants, which I think is also quite a challenge for them. So we are looking to get 510K. We're going to push it. So at the moment, SalivaDirect is rolling out of Yale. So first of all, Yale is not set up to be a holder of a 510K as sponsor. So we have started SalivaDirect Incorporated. So it is going to be a non-profit. The EUA is going to be housed with SalivaDirect, and then as the 510K. I'll be staying at Yale with my lab, but continuing to work in collaboration with the SalivaDirect Incorporated. So the non-profit is really going to help to continue to work with the labs, oversee the lab community, help with the regulatory, but also see what else we can be doing to continue to elevate saliva as a low-cost solution for sustainable diagnostic or screening efforts. So working in collaboration with the different labs, different funding agencies to see what other sort of approaches can be developed or designed. So we're actually having our second annual conference in June. There was supposed to be a picture here in June in New Orleans. So if anyone wants to come along, it will sort of be a little bit similar to this, but also with more on the sort of different R&D that's going into saliva as a sample type as well. So, yeah.
In your stability study, the freeze-thawed samples had a lower CT value. Was that ever considered to be part of the protocol, maybe instead of using inactivation?
No, because I think, interesting point. Didn't even consider it. I think didn't consider it because of just the way that samples are received into the lab, and depending on what sort of freezers or not people have available to them, and also the time for testing. So, a lot of our labs were reporting results within sort of 8 hours to their local communities, their schools. So to be able to get those really timely results. And in the end, I mean, lower CTs, but not often the difference between, a positive and a negative sample anyway as well. Yeah.